This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
He is a 70-year-old physician who has undergone vitrectomy for retinal detachment about a year back, and now has developed this cataract. And at slit lamp examination, I'm careful to analyze and see if there is any pre-existing posterior tear, which is a possibility when a patient undergoes vitrectomy. It looks fine. There is some amount of nucleus sclerosis along with the posterior subcapsular opacities. So at the slit lamp examination, it's critical to evaluate and rule out the presence of a pre-existing posterior tear. This patient is also myopic, and for which he developed a retinal detachment. So in such an eye, there are few concerns when you're going to do cataract surgeries. So the number one would be like this vitreous cavity is filled with just fluid and we don't have the vitreous gel. So the gel support which is given to the eye is not there, and along with that, patient is also slightly myopic. So in these vitrectomized eye, we expect that the lens is positioned slightly below, and because of the coexisting myopia as well, there's always possibility of a low scleral rigidity. This results in sudden deepening of the antechamber whenever the probe gets into the eye. And there is always chance of inducing lens iris retropulsion syndrome, or else the reverse pupillary block syndrome. And all these factors add on to also an increased risk of posterior tear occurring in these eyes intraoperatively. So these are the considerations which we need to have when we're going to do surgery for this patient. Patient had significant astigmatism as well, so I'm planning a toric lens. In this patient, the markings are done and the lens is supposed to be aligned at 178 degrees, and that's what I'm doing now. The plan is to have an adequately sized rhexis. I'm planning a slightly bigger rhexis in this patient. This is to ensure that the nuclear fragments can be pulled out of the bag and I don't have to work very deep, which is a common thing we encounter when we don't have the vitreous jelly behind it. It looks like we are working way deep in the eye. So I just want to pull out the fragments. So that's the reason I'm going to plan a slightly bigger rhexis. And let's see how things turn out. OVD is placed to deepen the chamber and care is taken not to overpressurize the eye. I'm using the forceps to perform the rhexis. I just want to be a little bit slow and careful just to ensure that I get the appropriate size. It looks alright and adequately sized. Time to perform hydrodissection. Now, since I was pretty sure that there did not seem to be any evidence of pre-existing posterior tear, I'm going ahead with doing hydrodissection. I just burp out the OVD first, and gently, using very little amount of fluid, I'm doing a hydrodissection, and then I'm just trying to tap the lens and to let out the fluid which is there. I'm attempting to perform hydrodelineation, but doesn't seem to produce any golden rings. I don't want to use any excess fluid. I just stop there and come out. I'm refilling the chamber with just a little bit of OVD. I'm using a Sinskey hook just to confirm that the nucleus mobility is there. I'm just rotating the nucleus a couple of times, which ensures that the nucleus is mobile. I'll be now introducing the phaco probe into the eye. Now this is the moment when we'll have this evidence of sudden deepening of the chamber secondary to the reverse pupillary block or the LIDRS. To prevent the lens iris diaphragm being pushed down suddenly, we have to lift up the iris. So I switch the Sinskey hook which is there with an iris repositor which goes in first and it is placed under the pupil, and the iris is lifted up as the phaco probe is introduced inside the eye along with the irrigation. So this ensures that the sudden deepening of the chamber is prevented, and basically we are going to avoid the occurrence of the reverse pupillary block. So I prefer to use this iris spatula instead of the Sinskey hook to lift up the iris. This is one trick which I use to prevent the lens iris diaphragm retropulsion. These are the settings which I'm going to use. Essentially what I'm doing is I'll be working under low pressure The fluidics are extremely important in these eyes, so I'll be working in a low pressure environment, meaning that the bottle height is going to be reduced. So I'm going to work here with the bottle height about 50 centimeters throughout the case at every step of the surgery, because this ensures that the chamber is not too deep. And because I'll be working with a lower bottle height, to prevent any antechamber from shallowing, I'm going to be reducing the AFR and the vacuum to compensate for it. So these are the settings, and I begin with my epinucleus settings just to remove out all the superficial epinucleus in cortex. The second instrument, I've swapped the iris spatula with the Sinskey hook. And once the superficial epinucleus is removed, now is the time to deal with the nucleus. Now in this case, I'm anticipating a slightly softer nucleus, and I was expecting that it could be slightly difficult to crack. My plan is to do something like a stop and chop technique in this patient, and let's see how things turn out. So these are the sculpt settings, and as the sculpting is being done, careful that it is a long, thin track which is being created. And once I've reached the about 60% depth, I think this should be adequate enough to split the nucleus into two halves. The nucleus could be split easily. And I'm trying to rotate the nucleus so that I get the heminucleus into the right position. And please watch, I'm going to use the bimanual technique of rotating the nucleus, wherein the dialer and the phaco tip act together to move the nucleus. This is a better way to minimize any stress on the zonules. The heminucleus is again divided into two smaller fragments, and then each of these fragments are pulled out of the bag and emulsified. Again, please note the settings here. Again, the bottle height is 50 centimeters, and chop and the other flow rate and vacuum are consistent with that. The flow rate and the vacuum are slightly reduced from my usual setting, just to compensate for the low bottle height which I'm working on. And the emulsification of the fragments is begun. Now, since the rexis is slightly bigger, the nuclear fragments are popped out of the bag into the antechamber, and they're quickly emulsified. The second heminucleus is also pulled out of the bag and emulsified quickly enough. The nucleus was not so dense, and managing the nucleus was relatively easy. Now we're left with a sheet of epinucleus in cortex, and the epinucleus does not look to be very thick. The last fragment is emulsified, and before the handpiece is taken out, I'm going to inject a viscoelastic through the side port just to maintain the antechamber as the phaco probe is withdrawn. I need to remind myself that the risk of PC tear still exists while aspirating the cortex, because these capsules will be relatively thin and more vulnerable for rupture. Gentle irrigation is being done just to loosen out all the epinucleus which is there. And then the chamber is filled with OVD, and then I'm going in with the bimanual irrigation aspiration. Again, to prevent the reverse pupillary block, as I'm entering into the eye, I keep the bottle height very low. I begin with a bottle height of just 30 centimeters. That's what I'm trying to check before introducing the irrigation cannula. We're just seeing trickling of fluid. Now once it is inside, and once I begin to aspirate and the chamber is evacuated of some of the OVD, then the bottle height is gradually raised to maintain the antechamber. This ensures that the patient does not experience sudden pain. The primary reason for these patients to experience pain is when there is a sudden deepening of the chamber, and the stretching of the ciliary body is what causes them pain. For me, the best strategy is always to go in with a very low bottle height, and then once the aspiration begins, gradually increase the bottle height. This minimizes the sudden stretching of the ciliary body, and definitely the patient is much more comfortable. The epinucleus in the cortex is now being aspirated, and there are some fibers which are sticking onto the posterior capsule, which I'm wary of. I don't want to do any polishing in this patient. I'm just trying to irrigate with BSS, that this loosens out all the fibers which are sticking around, and they just get irrigated out. Thankfully, the strategy of irrigating out worked, and the posterior capsule looks clean except for a small paracentral area where there still looks to be some fibrotic or a calcified element, but I'm not going to touch it because I have planned a toric lens and I don't want a disruption in the posterior capsule. So I'll deal with that element later on if at all it's going to have any visual consequences. So I was very clear about this aspect. Time to implant the lens, and the lens is being placed into the bag. The lens implantation is nice and easy. Time to remove the ovary. As the irrigation cannula is being introduced, again I remind myself that it's time to reduce the bottle height again. Having a mechanized stand does help to vary your bottle height. So the eye is already filled with viscoelastic. I don't want to pressurize it again with the infusion. So I begin by using a very low bottle height. The bottle height comes to around 30 centimeters now. And as the aspiration begins and the ovary is getting evacuated, gradually my assistant is going to increase the bottle height. Now it would have gone to 50 centimeters and now it would have gone to 60 and 70. So this gradual increase in the bottle height ensures that we don't have sudden increase in the infusion pressure. It also is less detrimental on the posterior capsule, and also the patient is much more comfortable. So you working with very low pressure does increase the surgical time because every step becomes a little bit slow and it takes a slightly longer time to evacuate all the ovary both in front and behind the lens. And removing the ovary behind the lens is extremely critical. Since this is an toric IOL, we want the posterior surface of the lens and the bag to be totally devoid of lens so that the lens contact is good and it sticks onto the bag very early. And this is all possible, just a matter of time. The only price we need to pay is a little bit more time, and because it ensures greater safety in such eyes, it's worthwhile spending those extra few minutes. Finally, every bit of ovary seems to be out. Before removing the irrigation handpiece, I'd like to do stromal hydration of the side ports. It is done. And then the main wound, the other side ports are hydrated. I like to keep the eye a little bit soft, not too hard. Lens looks to be well centered, and that's it, the case is done. These are the first day post-op pictures, and the patient is doing pretty fine. To summarize, doing cataract surgery in a post-vitrectomized eye requires some amount of planning. These are some of the anticipated issues which we should be concerned about. Number one would be low sclerorigidity, lens iris diaphragm retropulsion syndrome. And to counter these things, we need to ensure that the entire procedure is done with a slightly low pressure, that is with a slightly lower bottle height, and using the right parameters to compensate for this low bottle height. Lifting up the iris before the infusion starts helps us to prevent this reverse pupil block issue. This ensures that the patient is much more comfortable. Lastly, we need to remind ourselves that the incidence of PC tear would be relatively higher in such eyes who have undergone vitrectomy. So we need to anticipate it preoperatively, look for it at slit lamp examination, and then plan accordingly. That was it. Hope you found this useful. Thank you for watching.